So welcome back, and we will go forward with fluid therapy in trauma patients with Dr. Chris Byers. The stage is yours, Doctor.
Welcome back from lunch, where we will now fall asleep while we talk about fluid therapy. So, what we have to discuss over the next 30, 40 minutes, general approach to shock. I want to make everybody aware of what is termed the lethal diamond, and we'll talk about appropriate volume resuscitation and monitoring for patients that have experienced trauma. So, to reiterate, we're always going to do our primary survey first before doing a complete physical exam. So as basically every one of us have said thus far, you're going to focus initially on your A, B, C, D, E's, and to decide, for example, is this patient in respiratory distress? Do I need to capture the airway? What does the heart sound like? Are we having a dysrhythmia? Do I need to intervene pharmacologically to address that? Obviously, we'll be focusing during this presentation on fluid therapy, but recognize that although it's not a topic for discussion right now, sometimes trauma patients need more than their airway protected and antidysrhythmic drugs and more than fluid therapy. Occasionally, they will need medicines to help the heart contract stronger or to improve their systemic vascular resistance, make the tone of their peripheral vasculature better. Most of our trauma patients are going to be experiencing some type of hypovolemia, whether that is because they were bleeding, they have leaky blood vessels, or blood is pooling in inappropriate places. We need to be concerned about hypovolemia in our traumatic patients. And although this isn't what we colloquially call rocket science, if you see evidence of hemorrhage or tissue that's been obviously traumatized but maybe isn't actively bleeding, maybe it did bleed initially. And when we do blood work, packed cell volume and total solids become a very, very important factor to consider in your overall patient evaluation. But I want you to be very aware about splanchnic contraction, specifically of the spleen, that can temporarily and falsely make your packed cell volume or hematocrit look better than it really is. So again, as many of us have already said, it's not necessarily the PCV or packed cell volume that we want to pay particular attention to in the acute and peracute phases. It's the total solids, because your protein level is not going to be falsely and temporarily elevated the way your red blood cell count may be because of splanchnic contraction. The reason we care about hypovolemia is we're trying to prevent our patient from developing shock, or if they are in shock, prevent their shock state from progressing. And what we talk about in shock is oxygen delivery, or DO2, versus oxygen consumption, or VO2. Under normal circumstances, while you're sitting here right now, you have more oxygen than your body needs. The supply exceeds demand. But in patients that have experienced trauma and have subsequently entered into a shock state, they reach a point where oxygen demand or oxygen consumption is not met by the supply. So if you don't have enough oxygen being delivered to the tissues that are demanding that oxygen, we enter into a state of anaerobic metabolism, which tissues understandably don't like. We see lactate increase, we see base excess increase, we see the inflammatory cascade become activated, which perpetuates the cycle of tissue inflammation. None of this is understandably appropriate. And when we don't have enough oxygen to meet our demand, by definition, that is shock. Our tissues are hypoperfused, and so the mitochondria are unhappy. And when the mitochondria are unhappy, cells start to die. When enough cells start to die, the organ becomes dysfunctional and starts to die. And then obviously if enough organs become dysfunctional or die, we die. Our patient dies. And so we want to be as proactive with our stabilization efforts, including with fluid therapy, to either prevent a severe shock state from happening in the first place, or if they are presented to us in shock, to halt that progression. Yesterday, you guys learned or were reminded about the major types of shock: cardiogenic, distributive, hypovolemic, obstructive. But I want you to also remember that each one of those types of shock has a stage of shock. And some of the common phraseology we use is compensatory, early decompensatory, or late decompensatory. Sometimes late decompensatory is called terminal shock. How do you differentiate which stage of shock a patient is in? It's based on their physical exam. And so this is why the primary survey becomes so important. As a result of performing a proper triage, you should be able to ultimately not just say that, yes, my patient is in shock, but rather you should be able to say, my patient is in early decompensatory hypovolemic shock. We should be able to put some adjectives in front of that shock terminology that describe both the type and the stage of shock with which that patient is living. When we use the term compensation, we're talking about two different things that are happening simultaneously. Number one, the renin-angiotensin-aldosterone system, or the RAS system, is triggered. So why does the RAS system become activated? Because the body is saying, I don't have enough volume within my intravascular space. I need to hold on to as much volume as possible. So renin is secreted. Aldosterone is secreted so that we're holding on to sodium. If we hold on to sodium, we hold on to chloride. What is sodium plus chloride? It's salt, right? And by the Gibbs-Donnan equilibrium, back to first year of school, Gibbs-Donnan equilibrium says that water follows salt, okay? And so if water follows salt, if the body holds on to sodium and subsequently sodium chloride, it's going to hold on to water and try and preserve your volume. At the same time, your sympathetic nervous system is also triggered, which ends up resulting in vasoconstriction to try and improve blood pressure, try to keep everything in the core. Cardiac contractility is increased, as is heart rate. The lethal diamond of trauma and shock is something that I want you to commit to memory, because as you treat a shock patient and get some minimum database data back, you should be looking for evidence of any one of these components. But if you document metabolic acidosis, hypocalcemia, coagulopathy, and hypothermia, you need to put some oomph in your step to working on this patient very expeditiously. Put another way, your blood pressure should go up, your sphincters should tighten, and you should get to work very quickly on this type of patient, because a patient with these 4 abnormalities is telling you that they are actively trying to die. So, a trauma patient that is presented in any type of hypovolemia needs some resuscitation. We need to get intravascular volume back. And so that begs the question, how much do I give them? Well, it depends on the stage of shock. A patient that's in the late decompensatory stage of shock in general requires more fluid than a patient that is in compensatory shock or in early decompensatory shock. What we do know is that we no longer want to just pump them randomly full of fluids that are of large volume. If we give large volumes of fluids to all these shock patients, we have a really good job of diluting coagulation factors, of making hemorrhage worse, and all around hemodiluting the blood. None of those are good for our patients. And so this is where the term endpoints of resuscitation, or EORs, comes into play in trauma medicine. What do I mean by EORs? I mean you're going to give a specific volume intravenous bolus, and then you need to assess how your patient did after receiving that bolus. And are you happy with how they responded? Did blood pressure come up? Did lactate go down? Did urine output increase, etc.? These are some of the common endpoints of resuscitation that are evaluated in dogs and cats. For every trauma patient, it doesn't mean that you're going to monitor all of these. In fact, I rarely have a central catheter to measure central venous oxygen saturation. But is it something that we occasionally do monitor? Of course it is. Think about it. Very easy to serially monitor vital signs and mentation, pretty easy to check a pulse oximeter, very easy to check blood pressure, and then we need some blood. But the point is, if you give a bolus, you must evaluate how your patient responded. So, in the world of trauma medicine, there are two novel strategies that have been explored and discussed to some degree. Number one is called delayed resuscitation. So you have a traumatized patient that is bleeding. With the delayed resuscitation strategy, you do not give any fluids until the bleeding is controlled. And in several human trauma trials, this approach is associated with higher mortality rates, sometimes significantly, sometimes not so significantly. Do we have any data about veterinary patients benefiting or being negatively affected by delayed resuscitation? Not clinically. So we don't really talk about delayed resuscitation for dogs and cats, at least at this point. But something that we do talk about as a component of something called low volume resuscitation is something called permissive hypotension. So you will give them intravenous fluids, but you're not going to target a normal blood pressure. So practically speaking, in a typical hypotensive patient, we want to see their blood pressure systolic be 100 millimeters of mercury or higher. In a traumatized bleeding patient, we don't want to do that. Rather, we want to let them be a little bit hypotensive. Not too badly, but just a little bit. And so instead of targeting greater than 100 millimeters of mercury, we're targeting 80 to 90 millimeters of mercury. And in multiple studies, this approach of permissive hypotension has been associated with some very positive things. So when you're seeing a traumatized patient with evidence of recent bleeding or active bleeding, don't target a normal blood pressure, but rather target a slightly lower systolic. And so permissive hypotension becomes one of the three pillars of our overarching response to fluid therapy for trauma patients. Number one, the first pillar is source control. Hopefully that makes sense. A patient's bleeding, you need to stop the bleeding. How you do that depends on what the cause of the bleeding is, where the site of injury. The second pillar, which is honestly quite a challenge for us because of cost and availability, is providing blood products. We call that hemostatic resuscitation, so specifically providing fresh whole blood or component therapy like packed red blood cells, platelets, and albumin or plasma. And the third pillar is what we talked about with the previous slide, which is permissive hypotension. And so we're going to spend a few minutes going through these pillars to make sure that we're all on the same proverbial page. So with source control, we need to stop the bleeding. It could be something as simple as placing a bandage. If you have an arterial superficial bleed, you're going to reach for some hemostats and clamp that bleeder. Sometimes trauma patients develop an antifibrinolytic state or a hyperfibrinolytic state, and they benefit from antifibrinolytic properties. So, for example, giving drugs like aminocaproic acid and tranexamic acid. However, as has been mentioned yesterday, we need to pay attention to the timing of the administration of these drugs. Some human studies and some animal research studies, like the CRASH-2 study in humans, said if a drug like TXA was administered within the first 3 hours, not associated with badness. If administration happened after 3 hours, there was a trend toward increased mortality. So if you're seeing a trauma patient that is bleeding and it took the owners 8 hours to get to you, giving something like tranexamic acid or aminocaproic acid is probably not the right thing to do. But if it took them 30 minutes to get to you and you can intervene very efficiently in a bleeding traumatized patient, giving a patient in that condition a antifibrinolytic medication is justifiable. And of course, to Sir Alp's chagrin, sometimes we need surgical intervention to stop bleeding. And that's when we are very thankful for those people that like to pick up the scalpel blade. Okay. Hemostatic resuscitation. I think it is fair to say that in the veterinary world, if we had blood products as abundantly available at times that our human colleagues do, we would use a lot of blood products. Why? Because if you lose blood, you want to replace blood. It's the equivalent. We don't often have that benefit or that luxury, even though we see patients all the time that tell us one way or another that they benefit from a blood transfusion. For example, over this Congress, you've heard a lot of us talk about point-of-care ultrasonography. Patients who have an abdominal fluid score of 3 or higher generally require a blood transfusion if they are a traumatized bleeding patient. But as we all know, giving blood is not always that easy. If you are going to give blood, there are some types of monitoring and testing that needs to be done before. I'm a little bit more aggressive with blood transfusion in my trauma patients. You've heard some people talk about wanting to keep the packed cell volume at least above 21 to 22%. For me, anything less than 25 in a patient that's been traumatized is something that warrants sincere consideration of a blood product. In our human patients, they don't talk about hematocrit or packed cell volume. They talk about hemoglobin. They always say, well, if your hemoglobin is less than 7, or if your hemoglobin is less than 8, or 70 grams per liter, or 80 grams per liter, then we need to talk about a blood transfusion. I mentioned that my dad was in the hospital, and they've been checking his hemoglobin like nobody's business, and thankfully it's not come close to being less than 8, so he hasn't required a transfusion. But I mention that simply to tell you that human physicians look at hemoglobin, while veterinary physicians tend to pay more attention to hematocrit and packed cell volume. In a patient who has been bleeding or who has bled from trauma, the ideal blood product to give them is fresh whole blood. Has red blood cells, has albumin, and has, at least temporarily, some active platelets. But finding a compatible donor for fresh whole blood in the heat of the moment is not often practical. So as veterinarians, we often have to reach for component therapy. And we can provide them, looking at a ratio of fresh frozen plasma to packed red blood cells to platelets. We either want to administer them in a 1:1:1 ratio or a 1:2:1 ratio if needed. The frustrating fact is most of us are not going to be able to use blood products the way that we feel that our patient would benefit from, because we either don't have access to those products or an owner can't afford that type of intervention. So that means you and I have to rely on other fluid types. And in our trauma patients, the fluid type that we need to reach for as best practice is an isotonic crystalloid. You know isotonic crystalloids as normal saline or solutions that are referred to as balanced electrolyte solutions. What are balanced electrolyte solutions? Normasol R, Plasmolite A, Phyllite, lactated ringer solution. So sodium chloride is not a balanced electrolyte solution. Which one is best? Well, great question. We are learning that, well, looking at sodium chloride, that has 154 millimoles per liter of both sodium and chloride. There is nothing physiologic about that. There is nothing normal about that. So to call 0.9% sodium chloride normal saline doesn't really make sense. It's a misnomer. We also need to remember that hyperchloremia or excess chloride can be associated with something called hyperchloremic metabolic acidosis. Most trauma patients are presented with a metabolic acidosis. Does it make sense to give them a fluid type that can exacerbate a metabolic acidosis? Well, also remember the pH of sodium chloride. The pH of sodium chloride is at best 5.5. It is the most acidic fluid that we have available to administer. Compare that to lactated ringers, which is 6.8. Compare that to Normasol R, Phyllite, or Plasmolite A, which is 7.4. Does it make sense to give sodium chloride with all that extra chloride and it being the most acidic fluid? Or does it make sense to give a fluid that has a lower concentration, around 90 millimoles per liter of chloride, and a more physiologic pH? So at this point, we reach for balanced electrolyte solutions over sodium chloride whenever possible. Well, what if you're in a scenario, you're working in a clinic or a hospital that only has sodium chloride? Then you deal with what you have. It's not that you can't use sodium chloride, it's that if you have options, a balanced electrolyte solution is best practice. Okay, so what is historically used in human medicine, despite all of that rationale and despite there being some really good evidence-based data, is they still reach for normal saline. And that's because they use all kinds of blood products with us because we have blood banks. Well, we don't have that benefit. And the reason sodium chloride is attractive to human colleagues is because there's nothing in sodium chloride that interacts with blood. So we don't necessarily embrace the data that we have, which this is one of the more recent studies out of the New England Journal of Medicine that looked at need for renal replacement therapies, whether patients developed renal dysfunction, what the mortality rate is, and significantly so, patients who received the balanced electrolyte solutions didn't die as much, and they didn't develop renal dysfunction as much, and they didn't need renal replacement therapy as much. What's our experience? Well, it's not in the trauma world. It's either in the laboratory world or it's in a different model like feline urethral obstruction. But all of our veterinary experience thus far does support the use of balanced electrolyte solutions over normal saline. From a practical standpoint, as a critical care specialist, I can't tell you the last time I infused sodium chloride in my patients other than small volumes to mix drugs in. But actual boluses or constant rate infusions to address dehydration and to provide physiologic requirements, it's probably been at least 15 years since I have used normal saline, unless I had no other choice because of lack of availability. So, permissive hypotension. We're not going to give huge volumes of intravenous fluids to these patients because we don't want them to reach a normal blood pressure. So yesterday you were exposed to much higher doses in terms of mils per kilo. Here I hope you can appreciate that we're using smaller volumes because we're not trying to create edema through triggering dysfunction of the endothelial glycocalyx. We're not trying to dilute out clotting factors because this is a patient who's recently bled or who is bleeding and you're trying to stop that. The only time that this approach is contraindicated is in a patient with traumatic brain injury. Bold, italicized, underline this in your brain. Permissive hypotension is not appropriate for a patient who has experienced traumatic brain injury because cerebral perfusion is so important to recovery in those patients. So, we talk about something called the Rose principle now when we discuss fluid therapy, especially in trauma patients. Rose is an acronym that we're going to go through. The R is for resuscitation. Remember those stages of shock. The resuscitation phase is for patients who are in late or early decompensatory shock. You're going to give them boluses of fluid to try and reach that hypotensive 80 to 90 millimeters of mercury systolic. What's the goal? To reach that target blood pressure and to bring them out of decompensatory shock. So, is every patient that has been traumatized and bleeding experiencing decompensatory shock? Thankfully, no. Sometimes they're just going to be presented in compensatory shock, which means you may not have to do any resuscitative fluid therapy. Under this principle, we would actually say we're going to do optimization fluid therapy, which again is only for patients that are not in decompensatory shock. They are just in compensatory shock, and we're trying to prevent them from decompensating. What this practically means is you're still going to give them intravenous fluids. You're going to give them intravenous fluids as boluses, but the amount that you bolus is even less because they don't need as much. And so one of the questions that is asked practically is, well, how do I know how hypovolemic my patient is? Well, we can use the physical exam characteristics for identifying shock stages, but we can also use point-of-care ultrasonography to, for example, look at the diameter of the caudal vena cava. Or if you like your echocardiography, you can look at the left ventricular end diastolic diameter to help you gauge the severity of your patient's volume needs. This is in dogs, and believe it or not, we actually have some data in our feline friends as well. The point is, a combination of your physical exam assessment through primary survey, your serial evaluations of endpoints of resuscitation, and the use of point-of-care ultrasonography can help you decide, is my patient in the resuscitation phase, meaning they're in decompensatory shock, or were they presented in compensatory shock? They don't need resuscitative fluid therapy, but they rather simply need optimization fluid therapy. Well, I said it's called the ROSE principle, so we've talked about the R and the O. What are the S and E? Well, stabilization and evacuation. So stabilization means this patient is no longer in shock. You've done your job, great job, high fives all around. This patient just needs daily physiologic requirements, okay? So essentially replacing insensible and sensible losses. When you're calculating this fluid volume, if you have medicines and other liquids going into the PET, that volume should ideally be incorporated into this overall calculation. Why? So that we are not providing excess fluid to these patients. We don't want to give too much because giving too much is associated with some meaningful problems. But hopefully, your patient progresses relatively quickly from the stabilization period to the evacuation period, which is where we're withdrawing intravenous medicines and switching to oral medicines. We're withdrawing intravenous fluids because our patient has started to eat and drink on their own. They're keeping it down. They're not vomiting. They're not having diarrhea. And in fact, you're getting ready to send them home. That's what happens during the evacuation period. They are on their way to rejoin their families at home to lead, hopefully, happy, high-quality lives. Sometimes using a balanced electrolyte solution is not enough. And so we may have to reach for some different types of fluids depending on our patient's response during that resuscitative or optimization phase. So, as was mentioned yesterday, we can use hypertonic saline in the 7 ranges, typically 7 to 7.5. And we can use lower volumes of this type of fluid to achieve similar volume expanding benefits. Or we can still potentially consider synthetic colloids like hetastarch or tetrastarch. But these fluids shouldn't be used willy-nilly. We really need to consider the appropriateness of them because of some of the potential adverse reactions associated with them, like acute kidney injury. In human medicine, we don't use these. One of my best mates from university is a human nephrologist, and he hasn't been able to use these, at least in the United States, for 15 years because use of this type of fluid in many human models, particularly those that have been associated with trauma, cardiothoracic surgery, and sepsis, have higher mortality rates, higher rates of acute kidney injury, and higher rates for renal replacement therapy. We don't have as much data in our patients, but what we can look at is the fact that in veterinary medicine, we have 3 generations of hydroxyethyl starches available to us. Each generation tends to get better. So the third generation, which is the most recent, is considered the most usable. Why? Because it weighs the least and has what we call the lowest molar substitution. And in the few veterinary studies that have been published looking at colloidal fluid association with acute kidney injury, those colloids, synthetic colloids in the third generation, like vet starch, are associated with the lowest incidence or zero incidence of acute kidney injury. So there are about 10 studies published, and it's almost split down the middle for don't use versus we didn't find an issue with it. And so we don't say never use a synthetic colloid. We say it shouldn't be your first fluid to reach for, and if you are in a scenario where you do need to reach for a synthetic colloid, you should be reaching for a tetrastarch or a third generation synthetic colloid. These fluids have also been associated with coagulopathies, and there are many proposed mechanisms for why this happened, but most of those studies have been in vitro, not necessarily in vivo or even clinical studies. And so we don't know how translatable those study data are to clinical real-life scenarios. So right now, we say, think about it twice before you reach for them. Doesn't mean you can't use them, but if you've already documented a coagulopathy, this type of fluid is probably not the best one to reach for. All of these patients need very close monitoring. How frequently and what you monitor depends on the severity of the patient's injuries, how clinically stable they are, how they're responding to the various therapies. Practically speaking, some of these traumatized patients need a dedicated medical staff member sitting cage side with them, continuously monitoring them. Others maybe need to be re-examined and re-evaluated a couple of times a day. And certainly the goal is, with all of the aggressive, intensive interventions that one will prescribe for a traumatized patient, including fluid therapy, if they're one of those patients that needs really aggressive, intensive, continuous monitoring initially, one would hope that as they positively respond, you can de-escalate the level of monitoring in those patients because hopefully they're getting closer and closer to being able to be discharged to go home to their families. So to wrap up, here is a real-life example. So Kayla, a 6-year-old female spayed golden retriever, she got knocked by a car and she was presented about 30 minutes later. From her primary survey, temperature is a little bit cold, her heart rate is high with weak synchronous pulses, her airway is patent but she's panting, she has pale pink tachymucous membranes, her mentation is quiet but she's alert, her CRT is prolonged, she's got what we affectionately refer to as road rash, but no visibly exposed bone, palpable features, and from a disability standpoint, she has normal reflexes and nociception. Yesterday, Dr. Pouzot-Navarrete exposed you to the animal trauma triage score. I encourage you to use this. It's really an easy score to use, and it has been validated. And anything higher than 3 in a dog has been associated with a higher risk for concern, death particularly. Kayla's ATT score was 4. So already, based on just her history and primary survey, we're really concerned, and we know that simply by having this score, she's at a higher risk for death. That tells the entire team that we've got to be very aggressive and efficient with her interventions. Her blood pressure was low, 66 systolic. We did abdominal POCUS. Her fluid score was 3 out of 4. We did thoracic POCUS, that was boring. No effusions, no B lines. Packed cell volume was 39% with a 59 gram per liter total solids. Glucose was slightly elevated at 7.4. Lactate was slightly elevated at 3.1. Ionized calcium was fine at 1.37. We have a metabolic acidosis. Our platelet count on the automated machine was about 100,000. We always look at a peripheral blood smear to confirm any documented thrombocytopenia, and we confirmed that it was true. 5 to 6 platelets per high power field. Remember, in a dog, 1 platelet at a high power field represents approximately 20,000 platelets. So her manual count was between 100 and 120,000. That matches reasonably well with the automated count. Her PT, PTT were normal. We did an abdominocentesis because of the presence of abdominal effusion, and that fluid was hemorrhagic with a PCV of 26% and a total solids of 56 grams per liter. So given all of that information, we know that she experienced blunt abdominal trauma. She has a hemoabdomen. Based on her primary survey, we said she is in early decompensatory shock, and certainly we have superficial dermal injuries that we will worry about at another time. These things are more important. Now remember from yesterday when we talked about pulmonary contusions, her thoracic POCUS was normal. Does it mean that she will not develop pulmonary contusions? No, because it could take up to 2 days for those to manifest. So we frame it to the owner as, right now, her lungs and her heart rhythm are fine, aside from being a little bit fast. But this is going to be something that we're going to serially monitor while she's with us, and will intervene if necessary. So, what did we do? We did an abdominal wrap. It's not just an abdominal wrap for this type of patient. You start at the toes, you wrap each individual pelvic limb, and then you come back around and wrap right to about this level in the dog. And I don't, what's that, L3? This owner, unfortunately, didn't have a lot of medication, a lot of finances, and we chose to do an autotransfusion. So we performed an abdominocentesis and immediately gave that blood back to her through filters, and we did give her aminocaproic acid. Why did we give her aminocaproic acid? Well, in the United States, getting tranexamic acid is a little bit more challenging than getting aminocaproic acid, and she was presented well within 3 hours. What would be ideal is to perform thromboelastography, which is the only way of documenting a true hyperfibrinolytic state. But on this day, our thromboelastography machine was not working, so we didn't have the benefit of confirming a hyperfibrinolytic state. But because of the trauma, because of the documented bleeding, and because she was presented within 3 hours, we made the decision to give her aminocaproic acid. When we provided fluid therapy, we said we're targeting 80 to 90 millimeters of mercury systolic because we are going for permissive hypotension. She doesn't have any evidence of traumatic brain injury, so there's no contraindications to this. She was a little bit cold, so we just used some passive rewarming strategies like blankets that have been heated or using a bear hugger or a circulating water blanket until her temperature was more appropriate. And we monitored the heck out of her. Using the Rose principle of fluid therapy, we strove not to give her way too much fluid. She was ultimately transitioned to daily physiologic requirements once her hemodynamic endpoints of resuscitation had normalized. And once she was eating greater than 85% of her resting energy requirements without vomiting or diarrhea, we discontinued intravenous fluids. And ultimately, her abdominal fluid score actually started to decrease after a day and a half. And she went home without surgery after 2 days. Went off. What are the top 3 organs that possibly bled that Dr. Moss shared with you? Spleen, liver, kidney. Good. Okay. So that is fluid therapy for the trauma patient in a nutshell. I want you to know the ROSE principle, because that is a relatively brand new principle for veterinary medicine. I want you to remember the lethal diamond, which is what 4 things? Hypocalcemia, hypothermia, metabolic acidosis, coagulopathy. Good, okay? And so if you are presented with a trauma patient who is bleeding, yes, they're going to need fluid, but you're going to embrace that low volume resuscitation protocol, which have what 3 pillars? Source control, hemostatic resuscitation if you can. That means using the blood products when appropriate, and permissive hypotension. Okay? Not too bad. Thanks, guys. You are so proud of yourself not sending your patients to surgery. Damn straight.
Yeah. Okay, any questions to Dr. Byers? Nope. Okay, I think everything was clear. They understood. So you are creating a generation that they will just be avoid to send the patients to a surgeon. Yeah. Okay. So we will basically we will start the new session, the special session with a surgeon and an anesthesiologist. But before that, I think the university wants to call the our sponsors to give their awards, and I will bring them. Just a second. So you will announce it. Okay, so this wonderful congress been with wonderful, amazing, legendary speakers, and also our technical part. Of course, the power of the university and the faculty, and our sponsors. So I want to thank to them. Maravet is here. No? Is outside? Okay, we can go forward. So Pharmavet distribution? Thank you very much. we are done. The others, Yuka bag is on the, I know, they are walking. Okay, so. Let's give you the stage.
Yeah.
Like this or like this?
Dark, really dark.
Dark?
Dark.
Really
yeah.
dark.
We
Yeah.
go dark?
Yeah, we go dark.
Okay. So, Andrei, very diagnostic. Yeah. What a So, the surgeon and the anesthesiologist wanted to go deep dark, so it's dark.
To not see us.
Yeah, yeah. Well, they heard us enough, so I don't think they really need to see us. So this was Seralp's idea to the combined lecture.
Because I knew that this will happen, you know, so revenge time, go forward.
Revenge time. Well, as opposed as you may think, actually anesthesiologists and surgeons are friends, and surgeons and internal medicine and criticalists are friends because we share the same goal. I mean, we would like to take all these little guys and girls safely to their owners back home. Sometimes we have different interests, but the major interest is the same. So, okay, let's get the show on the road. We first would like to present to you a little kitty that went flying out of the window, or jumped from the balcony. So a little kitty with high-rise syndrome, and apart from the thoracic trauma, which we talked about quite extensively already, a great lot of these kitties have a ruptured diaphragm. And as we already touched on in the previous days, we should really avoid stress in these animals because it will literally kill them if they have too much stress. So examine them as much as is possible without stressing them, and absolutely do not fight with them, because a kitty that's like this looks kind of okay, but there's a lot going on there. So stabilize them first, start the oxygen, give them analgesics. Check for do not lower the body temperature, but check for the body temperature that it's not too low, so increase the body temperature if necessary, and sedate or anesthetize if they are stable enough. So the radiographs, I'm sure you all seen radiographs like this before. There's no air where there should be air, and there's a lot of space where there shouldn't be a lot of space in the abdomen. That means that a lot of the actual internal organs have shifted. And these animals can be dyspneic for several reasons. The pneumothorax, there can be a pneumothorax without actual damage on the thoracic wall on the outside. So there can be leakage from either the bronchial tree or from the parenchyma of the lung. You can check for herniated organs, because as Chris yesterday already touched on, the stomach can move cranial to the location of the diaphragm. It can blow up because these animals are aerophagic, and the stomach gets bigger and bigger and impedes their actual ventilation. And of course there can be rib fractures, and we need to repair fractures, but not necessarily all rib fractures. So the pneumothorax can be caused by damage in the respiratory tract or the thoracic wall. There can be contusions of the lungs and of the heart, and Alex will touch on that a bit later. There can be compression of the lungs by the abdominal organ. There were some nice studies done, and in almost all of the cases, liver lobes have been herniated, followed by small intestine, stomach, etc., etc. So a lot of the organs can actually migrate to the thoracic cavity. The stomach we already talked about. We already talked about yesterday about trying to get in the tube, or if that doesn't it work. You can't get it past the cardia. Just try to find out where the stomach, the blown up stomach, is actually touching the wall, and try to perform a percutaneous gastrocentesis. Because if you decompress the stomach, it will more or less, you will lose the compression of the cardia, and it may be possible to actually pass the tube at that moment. Would you like to talk about this part?
Yeah, I think so. I can start. Can you give me the presenter? First of all, I just wanted to specify one thing about the hernias, and we can have different types of hernias that are connected to thorax. Today we speak about the traumatic diaphragmatic hernia, but what is another pathology that can look quite similar, and actually sometimes we see that on the radiographs just as a thing that we didn't even expect. Yes, pericardial hernia as well. What is the difference on the radiographs? So, generally you have a really nicely packed hernia around the heart in case of a pericardial hernia, and you don't have like a specific places, but in a typical traumatic hernia, we start caudally, and it's the dorsal caudal part where you can find the abdominal cavity content. So, and why we have chosen this case generally, because I think it's the most common argue between surgeons and anesthesia and intensive care, because you have a trauma, it's a surgical trauma. Does this patient requires the surgery? Yes. So we need to send that to surgery. But we want to start, because we internally understand that it's a surgical patient, and we have lots of things to debate here, but the animal needs to be sent in the surgery, so the question is the timing. So we usually start with stabilization of the patient, and all the time keep saying that I think the cheapest drug that saved more lives in the world is the oxygen. So you need to start with that. If you we even have this picture, keep calm, administer oxygen. So it gives you time actually to think how you will proceed this patient. And the oxygen can be administered in many, many ways. Depends on what would you like to do. Is the oxygen mask? But not all animals tolerate that quite quickly. And again, especially with the cats, right? Don't fight with the cats with the holding mask. If they don't want to be under mask, create something else. The oxygen chamber, if your clinic has one, because the typical chambers, they can be quite expensive. The neonatal incubators, also the options, if you will get it from human medicine. Elizabethan collar, and you need to cover that with the two lower thirds with the oxygen pipe going under the knee and the neck. But the thing that I will tell you right now might sound stupid, but I have precedents why I mentioned that. Don't cover fully. I saw the collar that was fully covered, and another thing, just remember physics, the temperature in the gases and how heavy or light they are. So it doesn't make sense if you have the oxygen flow from here and you cover everything from the top and you have the open bottom part, because then the oxygen will flow out and you have a loss of CO2 inside of the collar. So the simple thing, but remember the physics. And who has experience with this type of cages? Are you really happy and satisfied with, The thing that I saw with these ones, especially like at the first editions, the animals were stressed inside. And because like here you don't have any outflow of CO2. You know that there's the one problem that animals not only breathe in, they keep breathe out as well somehow. So yeah, on the first edition, like there was no absorption of the CO2, so that was the a problem. So yeah, don't forget to give them oxygen. Just to remind you, and we discussed that yesterday, that you hardly have just trauma of the diaphragm. You might have another additional 2 traumas. You can have the contusion of the lungs, and you can have a contusion of the heart. And we just know, based on the experience, the publication, the science, that there's the good chance of the pulmonary contusion. So it might, in this case, be 25 to 35% of all cases. And once again, just to you to understand what is the contusion as a term, it means the compression and decompression trauma. So we have the outside force that compresses, that pushes the lung together and then releases that. So it might crash the vessels, it might produce the trauma of alveolar, and if you have the acute case, it might occur already a few hours after the trauma, but we know that it can be the first phase that we don't see can be prolonged for 24 to 48 hours. So at least that's the one reason why to not take this animal directly to anesthesia and directly to surgery. Would you like to deal with the animal with lung edema or a lung contusion in anesthesia directly? I don't think so. Like we had quite a few of cases like this, but it's not cool to deal with them, although it's possible. So remember that pulmonary contusion is the combination of 3. So it's the edema, it's the pulmonary hemorrhage, and telectasis. And some people say, well, if we will get the contusion, if we'll realize that there is the lung contusion during the anesthesia, we will just switch the ventilator on and do recruitment maneuver. Will it help you? It will a little bit, but it won't solve these 2 problems. Like if the alveolar has no surface to gaseous exchange, the recruitment maneuver won't really help you. And once again, just to mention that the 24 hours is a borderline to development of pulmonary contusion. So sometimes you can't see that on the radiographs. So it's if you had a trauma that happened right now or like a few hours before, and you take your radiographs and you don't see any changes, it doesn't mean that it won't develop. And yeah, in case of just a lung contusion without any interventions, it still already can have a quite high mortality rate. So just remember to check that. There's like all possible signs of clinical signs of pulmonary contusion, from the nose bleeding, open mouth breathing, some paradoxal respiration, open mouth breathing. But you remember, you still have your animal with the diaphragmatic hernia, and most of these symptoms can be from the diaphragm, and the auscultation is not always diagnostic, so you might hear the crepitation, but not always. And of course, like you need to consider the patient with diaphragmatic hernia as emergency one, and as we many times say to you, I think like you all the time will be right in the case of trauma, that you will start with 2 things at least: analgesia and oxygen, and then evaluate the level of the stage of the shock and treat hypovolemia. So what we usually do if we have the patient with a diaphragmatic hernia, traumatic diaphragmatic hernia, we start with the oxygen and analgesia. It depends on what would you have and what would you like? So methadone, fentanyl, lidocaine. And now we have this cat. Raise the hand who will give butorphanol as an analgesia. Who will give methadone? Good. Who will give buprenorphine? Very good. Tell me why. Yes. And according to the latest publication, actually the analgesia from buprenorphine is similar to, in cats, only in cats, to methadone, although it's the partial mu agonist. What would be disadvantage to keep the animal on buprenorphine? Yeah, it's extremely difficult to reverse that because the affinity on receptors from buprenorphine is actually even higher than affinity with naloxone. Yeah, it's quite possible. And how often you need to give buprenorphine to cats? Yeah, 6 to 8 hours, and on some point, like you will miss the moment. We'll calculate like a 24 hours, and then you get to the surgery, and actually, I don't like have the animal on the buprenorphine during the surgery, right? So, but you know, people sometimes afraid of buprenorphine, especially surgeons. Sorry. Yeah, they're not afraid. They don't like. They say like cats afterwards. They act funny. They're watching stars. So all the time say that the first time of their life they're happy. So don't be jealous to cats. So yeah, we use rather full mu agonists. Sometimes we use also lidocaine IV. Fluid therapy in cats probably will start with 5 milliliters per kilogram just to see. Not in a minute, of course. And what we don't do, I don't know, like sometimes we feel like a parrots to every single lecture we say no corticosteroid. Bronchodilators probably won't be effective. Antibiotics in this case are not indicated, and the furosemide is not indicated as well. Remember about hypovolemia in this animal, so it's in a shock, you will have a volemic shock, you will actually get everything even worse. So if there is no response on the oxygen therapy, and I had a few cases actually with the cats that get worse on the oxygen and the pain management, and what that means, they get worse, the respiratory rate goes higher, they desaturated, and in these cats I prefer to put them sleep and ventilate, at least like to open the lungs. So methadone as a pre-med, ketamine, midazolam, or and propofol to induce them, and then I would maintain them on the isoflurane or ketamine, or just the ketamine and propofol. What is the disadvantage to maintain them on the isoflurane? Vasodilation in the shocked animals there wasn't. What else? It's extremely irritating. So, like, do we want to have any irritating agent in lungs? And another thing, actually, people absolutely forget that there is a heart actually in the chest as well. Surprise, surprise. That can be confused as well. And you know, that's interesting. If you go to research about the thoracic trauma and the contusion of the heart in the human medicine, it's 8 to 95%. So it might be not. Different research, and the 5 studies in dogs conclude something like this, from 10 to 96. So, but we consider all the time the myocardial contusion. So it might be localized myocardial edema, hematoma, and of course injury of coronary vessels, that we speak more and more about that as well. And there was the theory that the ECG is one of the best way how to evaluate myocardial contusion, but unfortunately this theory is not 100% sure, because the prevalence of a cardiac arrhythmias in all dogs with skeletal injury is 17%, and there is a dogs with both skeletal and cardiac injuries of 30%. So if you will just put the ECG probes on the animal, sometimes you don't see anything for this moment. So only Holter evaluation, like a continuous evaluation, will give you idea about arrhythmia and all of abnormalities. And why we have these abnormalities, just to remember, remember physiology, your favorite topic, action potential, difference in different muscles, right? And the cardiac muscle especially. So in this plateau, what is not possible to depolarize the cell again. So if you have the contusion of the myocardium, you can actually depolarize the muscle in any single moment. So it might give you premature ventricle contraction. So those of you who were in a workshop, how you will describe these complexes on the phone, explain the ECG. White and bizarre, yeah. Absent, yeah, but white and bizarre without P wave. So these are, I would say that it's too many of premature vascular contractions at the moment. So if there are one or two, it's not the problem, but here we have many of them. And you can have the ventricle tachycardia as a complication of that. So it's all the time the question between anesthesiologists and surgeons to cut or not to cut, and you have advantages and disadvantages of anesthesia. So on the one side you have the risk of adhesions or organ damages inside of the thoracic cavity. So you can have the tympany of the stomach, or you can have the compression of the intestines. Another side, you have pulmonary contusion, myocardial contusion, or different types of arrhythmias. So what I would say that, of course, this animal can't breathe properly because there's no diaphragm, and diaphragm is the major muscle for respiration. You have the compression of the lungs from the organs, and the lungs can get to atelectasis. And of course, you have also impact to cardiovascular system with the organs, so compression of caudal vena cava, decreased venous return, minute volume, and possible arrhythmias as well. So what is the main thing that I want to say you, that you need to be patient. There is I think, few indications for immediate diaphragmatic. Is the tympany of the stomach, is the internal bleeding, or the torsion of the intestine. But in all other cases, we know that mortality rate is lower if you will wait at least and stabilize for 24 hours, not cut directly. So, my protocol for that, usually, they are, first of all, ASA4 patients, so they might die. We pre-medicate them with the methadone and midazolam. Why we don't use alpha-2s in this case? We pack the heart already. We decrease the cardiac output already. That probably will be compensated by the rate, but it will cancel this compensation by alpha-2, so it's not a good point. And we induce either with ketamine propofol or alfaxalone. Mostly, and you remember you need to ventilate this animal. So, and can you ventilate? Can you do the diaphragmatic hernia if you don't have a ventilator? Yes. And the answer is yes. You can use the ambu bag, and years and years and years we did that as like this, or you use the the back on the machine. Of course, it's much easier to use the ventilator, apply PEEP on that to protect the lungs from further atelectasis during the anesthesia. But yeah, just remember that once you open the abdominal cavity, they can't breathe and you need to ventilate them, but don't hyperventilate.
Two pictures of the diaphragm, one from the thoracic view and one of an abdominal view. On the right, you can see the view from the thorax, and then you can nicely discern that there's a very large muscular part and a tendinous part in the center. And what we should never forget is that there are some really important structures crossing the diaphragm, and they may or may not be involved in the diaphragmatic tears. That's the caudal vena cava, the esophagus, and the aorta. And parallel to the esophagus, there are some important nerves, so you always have to be really careful that when you, with your inspection, but also with your reconstruction, that you do not damage either of these structures. The diaphragm can tear circumferentially, so at its attachment, but it can also tear in a radial type of injury. And sometimes these tears can go right towards the esophagus or towards the caudal vena cava. There's some studies done which percentage in dogs and cats, and most of the times you can see combinations of those as well. So if you go into surgery, the patient is stable enough to go under anesthesia, but then again, these are not patients you want to keep under prolonged anesthesia for a long time. Rolling them on their back doesn't help them ventilate. So from the moment that we started with the surgery, you really have to motor and be aware that all your things should be ready and you should work as fast as possible. So you clip the abdomen, you clip a piece of the thoracic wall. Why? Because afterwards you may want to place a thoracic tube, or you want to place a thoracic tube during surgery, which is an advantage because you can see everything. And that means that you need to clip a part of the thoracic wall as well. We approach the the diaphragmatic hernia through the abdomen. So we do a midline incision, and then we start with identifying which organs are actually in the thorax and try to bring them back very carefully into the abdominal cavity. What you should be aware is that sometimes there's a hole with a certain diameter. Organs pop through that hole and enter the thoracic cavity, and while they are there, they can get swollen because of the trauma, because there's congestion of the vessels, and that means that sometimes you can't easily return all the organs back into the abdomen. So sometimes you even end up making the hole bigger to get the actual organs back into the abdominal cavity. And especially in the chronic cases, there can be adherences as well already. So always be careful and don't pull on the organs too hard. Just be gentle. Keep them moist. So don't dehydrate the tissues. And then when you've put all the organs back into the abdominal cavity, you start to make your plan for the reconstruction. But what works for me is that I use stay sutures. I just look where the corners are in the parts of the diaphragm, and then I try to make the reconstruction, to make the puzzle, which part goes where. And that always looks very difficult, but most of the times it's actually quite easy. The tough ones are the ones where you have a big circumferential tear, because that location may sometimes be difficult to find. Then you do the reconstruction of the diaphragm. I'll show you a few pictures of that as well. In some publications, some older books, they mention that you have to debride the actual margins of the tear. Don't do that unless they're necrotic or something like that, but there's already there's not so much space, and if you cut a half a centimeter or a centimeter, it will only put more tension on your reconstruction. So only if necessary, and normally it's not necessary. I always use a multi-filament resorbable suture material like Vicryl, and as I said, I try to look for the corners first. Here there are some Babcock tissue forceps, but I prefer to use suture material. I first try to make the puzzle, and then I start actually with these corners, try to reposition them in the normal location where they should be. Don't tie the sutures yet, just pre-place them, and pre-placing means that you actually make the entire suture, but you don't tie the knot. So you still have room to check the thorax, because the typical one here would be an interrupted suture from here to there, an interrupted suture from there to there, and maybe one that connects them, but don't actually tie them already, because that gives you the room to start here at this part and at that part and at that part with a continuous suture. And as long as you don't tie the other sutures, you'll still be able to see into the thorax, because you don't want to perforate a lung or other tissue that's there. And always watch out for the other organs. Here's an example of a thoracic hernia in a dog. Here you can see the margins. This is where the reconstruction is finished. You see the continuous suture here, and there are some interrupted sutures on that side. A short hair cat, a lot of organs are, actually we have quite an empty abdomen here, and you need to carefully, because this is the colon, part of the spleen is in there, and you really need to be careful when you do this reduction. Another one, a dog, a lot of organs actually translocated to the pulmonary cavity. And here you can see, once you have reduced all the organs, that this is actually the caudal vena cava. So you have to be really careful here when you do your reconstruction, because you do not want to perforate the wall of the caudal vena cava, because then there's someone in the room who will tell you very quickly that it goes wrong, although you already saw it, but you lose all the blood pressure and the patient goes very bad in a really short amount of time. Thoracentesis, would you like to tell something about thoracentesis, or?
I think just the one slide that you have. Yeah.
This is just one, yeah. Okay, great. So when you do, when you close the diaphragm, there's still obviously air in the pulmonary cavity, and you need to evacuate that. I mean, a patient can resolve it by itself, but it will take a long time, and it will increase the respiratory effort that the patient has to do when it wakes up. So you have to evacuate the air. You can do that by means of two access points, actually. You can use the diaphragm, or you can use the thoracic wall. I used to use the diaphragm, make a little hole in a piece of the diaphragm that was still intact, place a circumferential suture around the tube, then evacuate the air, wait for a while, check whether it's still okay, and you can see if the thoracic cavity is in its normal shape again, because the diaphragm will bulge towards the cranial side. As long as it's still flaccid and moving, it's not, you haven't reached a subatmospheric pressure in the pleural cavity. And then you can pull out the tube and simultaneously close the suture. That was quite a hassle, and sometimes you lose a bit of the low pressure that you have. So that's why the last few years I just place a thoracic tube through the thoracic wall to evacuate the air, just to not fiddle anymore with the diaphragm, which has already is in a very bad shape sometimes. So But what you should be aware is the moment that you actually close the diaphragm, that there needs to be an open connection from the thoracic cavity to the outer world. Because the moment you close the diaphragm and the anesthesiologist tries to recruit the lung tissue and tries to fill the entire cavity again with lung tissue, the air that is outside of the lung tissue should have a possibility to get out. So there should be a sort of high pressure vent, because otherwise you will end up in more problems, with more problems. I'm sure you already know how these types of how the systems work, so better not waste any time on those. And no, I will not. Well,
Good.
You start with this one.
I think so. Yeah.
Yeah. Yeah.
Just one. First of all, do you have questions about diaphragmatic hernia? I would tell you about one complication that I got. It was the combination of a surgical and anesthetic complication. So we do these surgeries quite a lot, and it's quite a routine thing for us. And then suddenly, me and surgeon almost done, have discussion about the weekend. And then the blood pressure of the animal, when the diaphragm was closed already, the mean drops to 25 or 27. So I can't believe that. So I just changed the cuff, the asymmetric cuff, and it's still it's even now it's 23. So what happened? What do you think? The first thing, before I started even to evaluate, I said to surgeon, immediately remove sutures, open the diaphragm back. What happened? Yeah, they closed the vena cava as well. There was no backflow to the heart. So it's once in my life it happened, but just don't be too much relaxed during the surgery, so it might happen. So because the vena cava gets into the thorax in the same place, so it might happen that you will just occlude the vena cava. So be prepared for that. Monitor the blood pressure.
Sorry, I didn't hear the first part. Yeah, you extend the tear because that's the. I mean, you have to repair the diaphragm anyway. So and you should look at what is actually causing that. The cause that the organs can't return is that they are swollen. But you need. I mean, there's no point in making an extra hole in another wall. Just make the door wider so everybody can go back to the abdomen. Yeah, and the advantage is that you can plan where you make it bigger. So when you make it bigger in a location where it's easy to suture again. Yeah.
How many cases did you have when you have attachments between the organs?
Not very much.
Okay.
No, the cases where you have attachments are mostly the ones you touched on, the pleuropericardial
hernia. Yeah.
Yes.
It's interesting because you showed these pictures and from the publication, the article, and I think it's you need to be practical and rational because this article say that when you clip the animal, because of high risk of attachments, you need to be prepared for sternotomy as well, and and it said in every single cat that you put into anesthesia and the surgery for diaphragmatic hernia, you need to be prepared for sternotomy, and I never saw that.
I never had to use to perform a sternotomy in these cases, but now I clip them just to place a thoracic tube, just to don't have the accident that you take out the tube which you place through the diaphragm itself and you lose part of your subatmospheric pressure already.
Sure, thank you. So are you ready for the next one? Not too much tired. So that was an interesting thing. So we will speak about the mandibular fracture. But patient by itself made the thing interesting. So let's call that Fiona, 3.5 years old, fell down from the window, 4th floor, not too bad. Some bleeding from the mouth, can't close the mouth properly, and then it was referred to us from the other clinic, and it was actually the cause why they referred. There was just a mandibular fracture. They wanted to refer to dentistry. So how you proceed this cat? You know enough now. Like you have this cat who's possible, fell down from the window, 4th floor. What are you going to do first, second, third? Well, it's actually visually it's okay. It's just a bit of it's conscient, mentally fine. Just you know, the fracture. So you have this cat that came from another clinic. You put just in the stationary for 20. But what are you going to do in 24 hours? Analgesia, oxygen, surgery. Why not immediately? So, but the surgeon is there as well, like asking, should we do something? Like maybe we should. And remember, this cat is referred to us from another clinic, but the surgeon is here, and let's say it's Friday now, and he's not available on Saturday, Sunday. What we're going to do? Okay. So what you do some examination as well, like let's start with POCUS just to make sure. So the POCUS is normal, radiographs of thorax and abdomen are normal, heart rate is 203, respiratory rate is 28, and temperature is 37.2. What else? What your further ideas? Hypothermic. What? Since which temperature you will diagnose the hypothermia? 37.4. Any other ideas? For me, any patient that is less than 38 is on hypothermia. So with the Fiona, come on. We started with the oxygen. We gave, because like probably the cat is in a, do you think that cat with the fracture is in pain? We decided to give methadone, sedate it a bit, to give a bolus of fluids, see what's happening. And actually we wanted to prepare for surgery, but sometimes the thing doesn't go according to your plan. The assistant,
Can I make one comment?
Yep.
Yeah. Although this cat came from another vet, always assume, treat it just like you're the first one who sees it.
Yeah.
I mean, I think we cannot stress that enough, because you wouldn't be the first one who is within this window of 4 to 6 hours in which the cat seems okay, and then they go down the drain. So, and you don't want to be the knucklehead who brings it under anesthesia, tries to repair it, and ending up with a very poor cat afterwards, or even a dead cat. So
because they forward us, the cat is normal, the cat is okay, but it's never means that they did enough things. So the assistant did a mistake with calculation, and the thing with the calculation is always either 10 or 100 times. With coma. So Fiona got 2.5 milligrams per kilogram of methadone, 0.2 milligram of midazolam. She's lateral, she doesn't breathe. Her heart rate is 37, but still it's broken. So what is your plan? To cut or not to cut? What you're going to do, like it's done. And when my assistant came to me, like it's injected now, IV.
Oops.
Oops, sorry, but like we need to proceed somehow this cat further. So your ideas, your plan, like there is no option to run away. Although you really want.
You need emergency.
Yeah, exactly. You need to do something.
Call Amy.
Yeah.
The surgeon can go home for a while.
Well, that's the question. Would we let the surgeon just directly go home or not?
We'll keep him on a leash for a while.
Any ideas? What, like, because it's a real case. It happened, I think, months ago. And now you need to do something because it's still broken.
Can you think about reversing?
Yeah, what, think about, will we reverse? If we will reverse, with what? So who will give naloxone? Huh? After you intubate? Yeah, like I intubated the animal directly. But what are other options that you can have? Butorphanol. And what's the point to give butorphanol? You have one opioid. What's the point to give another opioid on the top of that? Partial antagonist. So it's the kappa agonist, mu antagonist. So we gave butorphanol. We started to titrate butorphanol to this animal. And it took 20 seconds after IV butorphanol when the heart rate got up and the animal started to breathe. We induced that with ketamine propofol because I still had the idea to send that animal to surgery. And that's why, what was the problem with naloxone? Then really like send the surgeon back home because you won't manage the pain. And now the question, the question that I get quite often, is it, if you gave butorphanol that is a mu antagonist, can you use fentanyl on the top of that? Why? You can't kick the butorphanol from receptors. Even like, it's not like a one army of 5 against one receptor of 1, but it might be, like I won't go with the really higher doses, because what people think on the wrong way about all antagonists, they think that antagonists actually destroy the agonist, but it's not true. It's just a question about kicking out of receptors. So what is the time effect of butorphanol? 1 hour, 1.5. So on some point, the fentanyl, the butorphanol will be destroyed by the liver and more receptors will be available. So fentanyl will start sitting on the receptor. So there is a point to give fentanyl on the top of that. So we use the concentrate infusion of fentanyl, lidocaine, ketamine as a CRI, and we proceed the animal to surgeon.
Yes. So we proceed to surgery. Remember, the cat Fiona was actually brought to the clinic because she can't close or open the mouth. So when you do the repair, you would like to know during surgery if you're doing a good job, because as obviously probably all of you know, if the cat has a symphysial fracture, one of the easiest repairs is just put a cerclage around the distal part of the mandibula. But believe me, I did it. You can over tighten. You can place the cerclage too loose. So it's very helpful if during surgery you will be able to check the occlusion, because if you made it really tight, but the cat can't close its jaw because the teeth are doing this, the kitty won't be happy, and we would like to have the kitty happy afterwards, and the owners as well. Then you actually have two different approaches. You can use this one, which looks quite dramatic, but it's not that hard. Um, you just palpate on the inside with your finger to check where the end of the mandibular is. Preferably, we place it between the mandibular and the hyoid. At least that's what I do. I think you'll probably do the same. Yeah, because then it won't interfere with these bones. And you actually just use an instrument to make a tent, make an incision, and then you can pull the tube through. Another option is this one, the tracheostomy. It actually depends a little bit on how you position your animal during surgery. Most of the times when I do a symphysial repair, I place the animal on its back, so a ventral recumbency, and then it makes more sense to do a tracheostomy, because then you're in the midline. As I mentioned yesterday, it looks very difficult, but it isn't that difficult, at least as long as you place a little pillow under the neck to just elevate the trachea a little bit. And then you have the possibility, I'll just skip these. Sorry, Saral. We showed that one yesterday as well. Quickly go to the kitty, then I'll go back to the other one. In cats, it's fairly simple. You clip the ventral part of the chin and prepare it as in surgery, and make an incision in the midline, and then place a hypodermic needle actually from the midline on the outside of the mandibula and the caudal of the incisor teeth, because the incisor teeth are really nice to keep your cerclage in place. And then obviously you use a wire and a needle that will fit, because that's the easiest way. And you go from the mouth towards the outside, then you retract the cannula or the needle and do the same on the other side. And then you actually, you're in this position, and then you twist, you reduce the fracture, and you twist. And while you are twisting the cerclage wire, keep checking the occlusion, because when you over tighten them, you will see that the teeth will go out or in, depending on the anatomy, specific anatomy of this cat. There's no use in it's not a good idea to over tighten them, because you get a malpositioning, but also you can get necrosis of the bone. It's really thin, and even if you're like a Hulk, you will actually be able to twist off the proximal part of the mandibula, because you just refracture it and then in a different location. So there's no need to have it very tight. You should have a normal apposition, because normally the symphysis isn't bone, it's cartilage. That's why it's so easy, it breaks so easily. So, okay. And then it should look like this. And you can just twist the wire, cut it, leave at least 4 twists, and then fold it back and suture the skin. And let's go back to this one, because that's in the cat. And in a dog, you have a few other options. This won't work in a cat, because the incisor teeth are too small. But in some big dogs, you can do this, or encircle the incisiva and just place it like this. And I never tried this option. I don't know if anyone in the audience ever tried this, but I would be a bit worried of pressure necrosis here. So, yeah, didn't work. You were up to some not boring stuff. Okay, I think that's the last slide. Any questions?
Any questions?
Sorry, what if? Have no teeth. Then it is a bit more difficult, because you need to have something to where you fixate the cerclage wire. I would say that my first thought would be to make a little hole and place the cerclage wire through that. On the other hand, most of the patients lose their teeth because they don't have a very very healthy jaw. But I think that would be my second option.
Yeah, I just
Yeah.
wanted to add
Yeah,
that.
yeah. If who has never placed an esophagus tube, E-tube, or doesn't know how to place an E-tube? That was a difficult question later today. Do you all have experience with an E-tube? It's like a feeding tube in the esophagus. How hard are they to place? No. Easy. Yeah, I'm 2 fingers in the nose with the light switched off. So it's fairly easy to do it. So in any case where you only have the slightest thread of suspicion that the animal might not start eating, I place in an E-tube. Maybe in 50 or 60 or 70% you take it out after a few days because Kitty decided to eat. But if she didn't eat, you wasted 2 days and caused the animal a lot of stress. And I don't know what you do, but I send them home with an E-tube. I have a really nice written description and I show it to them. We feed the cat with the owner in the clinic. Confirm and reconfirm and reconfirm. Okay, are you really sure? Do you want to do this? Are you feeling comfortable doing this? 9 out of 10 take them home right away. And actually it's a waste, I think, to not place it. Yeah.
Yeah, because we do like all the time. Otherwise, you need to again to anesthetize the animal and
again.
Yeah.
Good for you. There is still hope.
Any other questions?
Can I ask you one more question, Alex? Because there was a question that was raised to me by one of the colleagues yesterday. If you have a cat or a dog with atelectasis because of a pneumothorax or because, well, no matter what the cause is, are you aware that there's a certain time that you will not be able to recruit all the lung tissue again?
Yes, it depends on the time frame, but I would say that I had a cat actually with the diaphragmatic hernia that was quite a bit time already on with that. So I think they referred as this animal in at least couple of weeks from the trauma. So and I couldn't do recruitment, and the animal was desaturated. So usually I start with the low pressure and I give a bit more time, so at least 30 seconds when one recruitment. I can continue that like 5 to 10 times, but one lobe like never got back, so we just did the lobectomy on that. Because, you know, the thing that you want to do, increase the pressure, but if you will do that, you might damage all other alveoli, because like remember, in any tissue, and alveoli is a good example, if you will pull the rubber out, it won't get back to the normal shape, and you will make the wall thinner. So if you try on the 30 centimeters of water like 5-6 times and 30 seconds, and it doesn't go open, you might, as a last chance, try 35 to 40 centimeters of water by 5 seconds. If it doesn't work, then
take it out.
Take it out. Yeah.
Thanks.
Yep. Mm-hmm. Well, I don't do that aggressively, so I do that step by step. Normally, I don't. If it's like a routine procedure, I don't. Well, not for that case. I would use non-steroidals, but yeah, we do that, of course, just after the surgery, but not as to prevent the re-expansion. You mean the in the treatment of atelectasis? I do that manually. Yeah, I do them with machine, but I squeeze the back with my hands. I like to feel the lung from inside. Thank you. My dear colleague.
So, before we will proceed, I said yesterday we started that treasure hunt. We have hell of prizes, and now we will take out some of them to start to give some of the prizes. The thing that you didn't put, last minute chances. Anyone? Really? Do you really?
Yeah, I know the answer to my question.
Come on.
Hey, with these great prices.
So, what are the prices? So, we have some books. We have, for this, we have some books that Amy wrote and Chris Byers, an amazing book that about the feline emergency, you know. And the other one that we will give for Vets on Balkans, 2 people participation this year, Vets on Balkans Congress. So I will just ask Amy to pick up one for her book. One of your books. I mean, and the other. Because you have two. Yeah. So let's check. Crystal, je bol.
And the winner is.
So, one of the book.
I'll let her pick.
Yeah, okay.
All right, she can pick which
The
one.
other,
Yeah, you pick which one.
you wanna So because we are good people, you can also earn some other stuff. So the other prize is this really, by the way, to be serious, this is a feline emergency and critical care book, and this is amazing book. I advise everyone delightful at the end, because at the end, the other stuff that you will learn, that the aim of this Congress, of course, to learn about traumatology. But the aim of this Congress is to travel. And the aim of this Congress to stay under the umbrella of the veterinary faculties. So this year it was the first one is in our fabulous university. Next year it can go to France, it can go to United States, it can go to Holland, it can go to Estonia. We will figure it out together at the end. Doctor, stage is yours. Don't sit too much.
Hello. So here I am again with some content a little bit outside of the curriculum. So just want to get you to learn a little bit more about who we are as veterinary team members. We are a special species and we're an endangered species. So we have to protect think so? Okay, thank you. Yeah, so separation is so common now that you think, well, you know, I'm only going through a divorce. But by the way, going through a divorce, separation is just as stressful as losing somebody real close from you, or that partner would die. It's like, it's a big, big thing. That can be very hard on your personal life, even if it's common. Secondary traumatic stress, dealing with someone else's pain. So a family that is stressed, an animal that is suffering. See that overweight dog? Oh, that kills me when I see that in practice. Shelter dogs, abandoned pets. That's secondary traumatic stress from your job. That's occupational, from being a caring person. Cumulative stress, it's your life on a daily basis, family life, health problems, kids, kids, sick cats, sick animals, financial stress. So that's adding to the rest of the picture. Professional, so cumulative stress from the work at the clinic. People's expectations are on the rise, long busy days, tension within the team, liability, professional complaints. It's a wonderful job, but there's a lot on our shoulders. So why are we prone to compassion fatigue? Because we are not only doctors. Real doctors treat more than one species. You've heard this one before? Yeah. there are t-shirts with that. But it's a big deal that we take care of that relationship. We don't only take care of the pet. It's big, plus we have to be a psychologist, a financial advisor, we have to be a personal coach, and a doctor on top of that. It's a finance-driven medicine. Imagine you could work as a veterinarian with no limits on how much you could spend, and that'd be fun. And you need to know a little bit of everything on everything. Not a little bit, a lot on everything. And yeah, only profession performing euthanasia, that's all. That's why sometimes you're tired when you come back from the clinic. And everybody needs you. Everybody, the guy at the gas station, the nanny, the teacher, everybody has a pet and wonder why they're coughing. So I like that image because, you know, sometimes you will see 10, 15 clients in a day and you feel that you're so important. They made an appointment, they came to you because they care so much about their pet, and then you're just like, you know, number 11. You're like, I just want to provide as much of my person, of my knowledge, but it's really tough. And I think this image shows it really well. And what I want to show here is just that fatigometer, that empathy, that goodness that we have in us, it does deplete throughout the day. So my message here is, for the longest time, when I was a young veterinarian, I thought that this reservoir, that tank of empathy, of goodness, would fill up by itself, like thermal water, come from under and fill up, you know, naturally, because I'm a hero, because that was my dream to be a veterinarian, and I cannot complain that, ta-da, you know, Celine saves the world. No, at one point, you can do that for a couple of years, but then you need to fill up the tank. Guys, you're so young, please believe me, it's true. Invest in yourself. I like that one. Remember that. If the doctor treats men, remember that veterinarian treats mankind. It's much deeper. The stuff we do. We take care of their relationship. How many clients did I take care of their pet and their whole life was held by the pet, their mental balance? This is a big responsibility. So, yeah, we knew that vets are the coolest, but now you have a sentence. Whoopa. Yeah, we deserve to be happy and feel safe. Just saying, you know, sometimes in some clinics, you don't feel safe, you don't feel treated well at the level of what you invest yourself, you know, so that's important to remember. You deserve it. You treat people so well. You treat those pets so well. Painkiller, tender loving care, you groom them, you feed them. Who does that for you? You speak very nicely to the students, to your friends. Do you speak as well to yourself? Do you apply what you apply to the other people, to yourself? I didn't for the longest time. Our schedule are quite intense. Again, for the longest time, I wasn't having lunch. I was just like gobbling some food in between two cases while the sedation was kicking in. I had another surgery and I was just running. I was like, I'm so busy. I work so hard. I'm a good person. Yay. But why did I need to do that? We were just not well organized. So, for the longest time, we were doing consultation and surgery in the same time frame. There was 2 vets, one doing surgery, the other one consultation, and then we all mixed up, and then we were rushed all day long. And at one point, I'm like, why wouldn't we have 1 vet in consultation, 1 vet in surgery, and it's just easier. You just need to organize yourself so you're able to take a lunch break. I got to tell you a story about that. So I was doing consultation and surgery. So the vet tech prepared my cat castration while I'm doing a cat vaccination. So I come to the client, yeah, everything is good. Okay, thank you. Yeah, have you heard about parasites? Yes, no, okay, bye-bye. Then I go do my castration, and then I go back to another client. And then I look at my sandal after I'm done with the consultation, and I had a cat testicle on my sandal. The whole time I made the consultation with a cat testicle, and it looked like, the clamps you buy to make your sandal pretty. You can change them, it can change color, it can be a glitter, a diamond, or a flower, and I had that testicle standing like that. And this is when I said, you know what, I think we need to stop doing consultation and surgery all the time. That was the trigger. But so, I did that for so many years, and I thought it was so cool not to have any lunch. I would hardly go to the bathroom, and I thought, I'm like, yeah, I'm killing it. I was killing myself, actually. But I'm thinking, what if you would get a surgery done on yourself, and the surgeon would live his life like that, like no lunch, finishing at 10 o'clock at night, being back at the clinic at 7. Yeah, do you want to be operated by this surgeon? I don't. I want him to, have a better balance, to be working better. So that, just want us to stress that to just try to apply your kindness to yourself. Again, for so many years, I'm like, oh, I'm stupid, I forgot to do that. Oh, I'm dumb. Oh, why do we do that? What message are you sending to your team? Then everybody starts doing that. It's not an example. I wouldn't say it's toxic, but I don't think it's something good to do. Cuckoo. Okay. So be kind to yourself, be an example for your team, and start a trend. Let's just be positive. So if somebody in the team gets going and like, or starts bitching to another one, you're just like, let's not go there. Let's stay positive, everybody. And that really helped us in our workplace to have more fun. This is my nephew. He just loves to do flower arrangements. He's so cute. He's my example. I try to be as positive as he is. So when I was young, I used to admire intelligent people. Now I grow older, I admire kind people. At the vet school, I was in love with the smartest guy in the school. He's just like, and he aged, and he's not much more smarter, and he's not kind. I don't like him anymore. So I just want to share a piece of my wisdom. You recognize Robin Williams that said, everyone you meet is fighting a battle you know nothing about. Be kind, always, you never know. So I just have a story I want to share with you. I'm in the clinic, and I've got my vet tech. She does the pre-exam, and I can see she's very annoyed. She comes back to the consult room, and she's like, oh, well, like that client, like she doesn't want to give preventative medicine to her dog. Like she wants him to die from Lyme disease. Like, she's super judgmental. She's like 24 years old, and she's not judgmental to be mean, but she doesn't want that dog to be sick. But she's judging the person without the whole picture. She doesn't know what this person is going through. So I'm like, just watch me, vet tech. I'm going on stage, and she'll leave the clinic with all the preventative medicine. Trust me. So I'm like, hello, Madame Bouchard, how are you today? So you think like your dog doesn't need preventative medicine? Because we're in the area where there's most Lyme disease in the whole Canada. So you really want to kill your dog? What's the problem? Why don't you trust us? You've been doing it for 5 years. What's up? Is it the money? Like you You think you're smarter or what? But I'm not exactly like that. I'm just like, yeah, so I wonder, why when you take the preventative medicine? And then she goes, yeah, no, I won't take it. Okay. Why is that? Well, because I usually walk my dog, but my son was going to get married, and he went partying with his friends on a snowmobile on the lake that is frozen. And then something happened, and he went through the ice, and he's dead. So I'm not going on walks anymore because we didn't find his body. They're looking for him. So until they find my son's body, I'm not going to go walk my dog. This is what I do. Oh. Thank you so much for sharing this story with me. It's very nice. I really appreciate it. She didn't have to say everything, right? And she said, then they found the helmet yesterday. The police found the helmet, so I'm confident they'll find him soon. I'll go walk again, and I'll take the medication, okay? I'm like, yeah, perfect, super. What you want me to trim the nails, maybe, free of charge? What can I do for you? So I go back to the vet tech, and I tell her, and she's like, oh, my God. So that was the story. Then I go back to the clinic at night, and she sends me a text message, and she's like, I saw it on the news, they find him. They find the lady's son. They find his body. The lady came back 2 weeks later, and she took the medication, and yeah. So you don't know. My clients, I don't know you, Chris, but my clients go through so much tough stuff. It's unreal. So not only that, it's good not to be judgmental, but it's just so tough on us when we judge them all the time. Like, why aren't they doing that? Why are they overfeeding? La, la. It's an exercise to try to stop that. We have a wonderful resource, spiritual master in our life. Everybody's got pets here, right? So we have spiritual masters in our houses. Let's get inspired by them. This is my hypervigilant dog. But everything they do, we should be doing. So as a reminder, look at your pet and how cool they are with themselves. So that my dog stretches multiple times during the day. I should do like him. I only do it once a day, but they stay adventurous, always ready for an adventure. As we get older, like, nah, look at your dog. Me time expert. They take care of themselves all the time. Yep. Listen with the intent of understand, not respond. I think this is great. They just listen to us. Get excited to go outside. The hardest thing is just to go past the door. Once you're outside, it's beautiful. Perseverance is all you need. If you look at it, they always get what they want. You just need to keep on asking. Asking, pushing. Okay. And they never wonder if they're good enough. They're like, I'm cool. I'm the best dog. Yeah. That analogy I just want to share with you. Sometimes we have a bird and we have a little thing bugging us, and we're like, it's only that. It's only my hair color I don't like. It's only my mom calling me 10 times a day. It's only that. But just remember that if you're carrying something, even if it's not heavy, like if I have to just keep that up my head, it weighs nothing. But if I gotta do it the whole day, it's gonna hurt my shoulder. It doesn't matter how heavy it is, it's the time that you hold the burden. So sometimes you just gotta put that down a couple of minutes so you can take it again. So that's why meditation exists. You would think I'm good at meditating, right? I look like I drink tea and I make pottery and everybody gives me tea. I don't know why. I don't drink tea, I drink coffee. But I've tried to meditate since I'm 11 years old. Who meditates here? Is there somebody that can meditate? You guys, amazing. I'm so envious. I'm not able to do that. Started at 11 trying to meditate, okay? Just hate it not to do anything. It's frustrating. But just want to tell you, I found the way finally. I do awake meditation. So I just do floral arrangements. I just do creative stuff. So I just weed. I do stuff. I'm awake, but I'm not thinking about my burden. I put down my burden for a bit and do other things. So try to find something. If you're not able to do meditation is ideal. You don't need anything. You just sit down or even stand. Little tip, showering when you come back from the work, it can help you get rid, down the drain the client that said that we're only there for them and bye-bye, and the drain, vroom, shower. Or I used to listen to the news, maybe Céline, we were talking about that. I want to get smarter coming back from the clinic. I dealt with all that shit, and then I still want to be, informed what's going on in the world, in Israel, Palestine, everything. Okay. So I listen to stuff, and then it gets me even more stressed out. So now I listen to podcasts. Who listens to podcasts here? You guys, you're killing it. Yeah, it's just infinite source of inspiration, positive stuff. There's so much cool stuff in the world happening, but you don't hear it in the news. It's only bad stuff. But there's amazing stuff going on. And I just turn the music to the max when I want to forget about everything. Yeah, we'll skip that. That's my office view, by the way. Not bad, huh? Oh, actually, I'm going to tell you about it. You are in vet medicine. You've done so many sacrifices. You're extremely smart people and passionate. You've got it all. If you don't like your job, just quit. Somebody during a webinar said, well, how could I fix my toxic work environment? Go through the door. Bye-bye. Go to another place. Don't fix it. You can't fix it. Amy, I don't know if you agree, but sometimes you cannot fix it. Just save your life. And look at the water bottle that you pay $4 at an airport. It's the same water bottle you pay at the gas station, $3, and $1 at the grocery. So if you're not valued, I'm not talking about money here. If they don't make you feel you're good enough, you're worth it, go somewhere else because somebody will find you beautiful. Because I went through that in one clinic. They made me feel like manure. I'm a great person, but I was coming into that clinic and I was starting shaking like today. Shaking, I was twitching in my face. I was about to give up vet med. It's my child's dream, it's my life. I'm like, nah, I can't do this. I went to another clinic and they made me feel like a rock star. So sometimes you just need to, it's so important, the team is so important at vet med. That just change, save your life. Okay, set boundaries, quickly. It took me a while to figure that out. And then people would bring their pet too late in the day, or they had waited two weeks, now they want me to save it. You'll see that in some traumatology so much. But we have to educate people around us on what's good for us, or what's not good. I tolerate that. I don't tolerate that. Myself, I was expecting people to have common sense and respect for me. But I invite you to just turn that around and just communicate that with them so they respect what you would like them to respect instead of expecting them to do it. And since I've tried that, I was very surprised. I set the boundaries. People, if they would come after a certain time, it would cost more, or I would tell them, well, you're going to have to wait 3 hours maybe. And they were fine. So you tell them, you educate them. It's a habit to set, and then you just celebrate that they respect you, and you're like, oh my God, this is so simple. I just needed to tell them. And yeah, it's very satisfying. Let's say, what's acceptable? How many hours do you want to work? Or do you not want to work? And then, it's if you're saying no to other people, you're saying yes to yourself, and you can last. Anyways, it's a short version of it. We could talk about it for a long time. But I finally managed to do it, listening to different speakers. Like Julie Capel, those are all available on the podcast. Mary Holloway Chuck, and there's thousands of them. I'm sure Amy talks about them somewhere in her book, so buy Amy's book. Rinse and repeat, and now I celebrate. Every time I set my boundary, I'm like, oh yes, you did it. So for the ones that are still not convinced about the podcast, that by the way are free on top of that, some of the best ones, and if there's some that you'd like to share, I added yours, Amy. I discovered yesterday Veterinary Team Training by Amy Superstar here, 20 minutes something, right? Like everything we're talking about today, it's in there, right, somewhere. How many episodes do you have, Amy, in your series? Yeah, imagine. Imagine it's waiting for you to grow out of them. It's fantastic. Vet Girl, tips on veterinary life. She's got a series on veterinary medicine and menopause. Just saying. You're too young, but I'm getting there. That's Andy Work. So yeah, Vet Blast I discovered lately. Super cool. Like in 20 minutes, what's happening in VetMed? VetMed is changing so fast. It's ridiculous. How can you be up to date? But you can listen to that in your car or in the metro, whatever. Yeah, more. Freakonomics. Who knows Freakonomics? Yeah, not amazing. I mean, what some economical or decision have on our society. And there is one episode that's called Stevie the Cat. Céline, we were talking about cremation. Amazing episode. They tested private cremation remains to check if they were really private cremation remains, and a lot of times they weren't. Super interesting about the world of pet cremation. You can learn a foreign language. It's really good for your brain. It's not a podcast, but who does not know about TED Talks? Everybody knows about TED Talks? They're 15 minutes talks, yeah? A lot of people go like that. Okay, well, wonderful. In case you don't know and you're afraid to raise your hand, it's just a specialist in anything will summarize whatever they think is worth for a person that is not from that field to know. 15 minutes. There is one, it's from Barbara Natterson, how it's amazing because it's a human doctor that started working with veterinarians and discovered how awesome we are. Listen to that, share it with everybody. And then from there, it changed. She's a cardiologist, and it changed her whole career, and she wrote some books and has been working on making vets work with human doctors. It's super cool. And I had the chance to give a TEDx talk. It's called The Hidden Face of Veterinary Medicine. It's about the financial impact of VetMed on us, veterinary professionals. Andy Work. Who knows Andy Work? One. Wow. Two. Yeah, of course. Yeah, this guy is like my idol. I love him. And just if you can watch that talk on Facebook on happiness and joy in veterinary medicine, to me, everything is in there. It's all about, our job is about up and down, satisfaction and disappointment, and it's all like, woo, like that. Amazing. It helps us see our job in a different way and not set our expectations. You know, happiness is not about being like that all the time. It's like, ooh, boom, bounce back, go down, bounce back, ooh, just like, yeah. And sharpen your axe. It's really good. It's about how to convince your client to do what you're asking them to do. There are ways, there are subtleties to make compliance happen. It's 15-minute talk, amazing. He has a podcast, he has a website. For the students, there's a super cool project from the student chapter of the AVMA, the American Veterinary Association. It's called the OK Project. When I was at vet school, a couple times I wanted to take my life. I went to suicide because I thought I wasn't good enough. And I thought I was the only one that felt like that. And then at the end of our program, we realized we all went through that, but nobody was talking about it. We just felt, because we were with like such performant people, it's hard to feel, you know, up to the level. So that's a really cool, they have a YouTube chain, and it's just helping you feel good enough. So it's easy to find. Since I put it there, since there's a lot of students. That's Vets in Mind. It's an app. It's free. You can put on your phone. All for VetMed people. Like, incredible. There's even useful apps on breeding, ovulation. I like the one on ovulation. I still didn't figure my cycle at my age. Anxiety management, and a lot of TED Talks in relation with VetMed. I'm almost done. Okay, Facebook groups. Just in case you're not part of a veterinary Facebook group, check it out. It's just crazy. There are some like DVM and gardeners. I love it. They're just vets going crazy on succulent plants, and it's just very, very funny, very refreshing. And there's also one, it's it's B&B. If you're going for, you're traveling, you'd like, maybe I'd like to go and stay at a vet's place. And they have, so there's so many things. And these groups are huge. DVM, mom with the DVM, that's really interesting as well. So my take-home message, it's natural to feel fatigue, to feel compassion fatigue, feel exhausted. It's part of the job. You're not working in the bank. And just do some efforts to refuel your tank, have fun. And if you want to know more about euthanasia, the stuff I shared with you yesterday, you can scan that QR code. It's free. It's race approved. We talk about pre-euthanasia sedation. We talk about cremation. We talk, so exciting, cremation. It's very interesting topic. Yeah. We have on Facebook a veterinary group, veterinary euthanasia. If you have an euthanasia, for example, it happened to me, I had to euthanize a rat. I don't know what to do. So you can reach out to these groups and find some answers real quick. People answer real quick. So there's 500 people there, and it's only veterinary members. No pet owners in there. If you'd like to have a eutabag sample, let me know. I've got some here outside. Some students that are still here, I believe, asked me for some examples of how people could make a ritual with eutabag, just painting. That's acrylic paint. That's just a marker. That's a pen. And then people sometimes just put some words on the eutabag and share that on social media. It means that it's important to them, and it brings them something. They want to share that with their community. So, and also some tools, some handouts on quality of life, how to bury a pet, coloring pages for kids, how to talk about pet loss with kids. We've got a handout. It's all free. You just click on it, download, print. And I still didn't figure out how to say that. Vă mulțumesc.
So we are giving a coffee break, and then we are back.